Hello and welcome. My name is Dr. Al-Hashimi and I am a recent medical graduate summer 2020. I have a special interest in orthopedics and therefore today I'll be continuing with orthopedic fractures. This is part 3 of a mini web series hosted by SDocs. If you have missed part 1 and part 2, I would recommend that you'd click on the links below and take a look at part 1, which would take a look at classifications of fractures, clinical features, investigations, and also management of fractures. Part 2 will also take a look at some important eponymous fractures, which I would recommend learning for undergraduate medical exams. So let's continue. So firstly, what we'll start off with is metacarpal fractures. Metacarpal fractures are types of there are 3 different types of metacarpal fractures. Metacarpal fractures are fractures of the bones that are located within the hand. These are a Bennett's fracture, which involves the first metacarpal. There is also a Rolando's fracture, which too involves the first metacarpal, and a Boxer's fracture, which takes a look at the 4th and 5th metacarpal bones. The Bennett's fracture is a partial intra-articular fracture of the first carpometacarpal joint, the CMC, which is found at the base of the thumb. It is brought about by axial forces which are imposed onto the flexed first metacarpal, or the thumb, seen in fistfights. So if we are to take the thumb and put them inside a fist, then close the fist and apply pressure, we'll see that these forces cause a fracture at the base of the thumb. The clinical features are fairly similar to the most other fractures mentioned beforehand. Pain and erythematous swelling at the first carpometacarpal joint, instability of the thumb and diminished function, and also what you'll tend to see is that their proximal fragment tends to remain. This is known as a triangular fragment, which is usually seen on an X-ray at the base of the first metacarpal. It is still attached by the anterior oblique ligament, which is seen here, to the trapezium below, which is attached to the first metacarpal bone. So the management that we tend to opt for a Bennett's fracture is conservative. If the Bennett's fracture is displaced by less than 1 millimeter, we can use a conservative approach. However, open reduction internal fixation or ORIF can be used in a surgical approach, or we can also use external fixation using Kircher guide wires or K-wires. These are percutaneous guide wires. A Rolando fracture, a complete comminuted intra-articular fracture at the base of the thumb, also involving the first carpometacarpal joint. It is slightly different from the Bennett's fracture. As you can see, this one is completely comminuted. However, this is a partial intra-articular fracture. The causes of this is axial forces onto the flexed first metacarpal, seen in fistfights. The clinical features are similar to that of a Bennett's fracture. There's instability of the thumb and diminished function at the CMC joint too. You can also see pain, erythematous swelling, ecchymosis. The investigations that will also show is the Y sign. The X-ray will show a Y sign. This is the Y sign here, as the comminuted fracture results in a dorsal and a volar or palmar fragment. The management of this is through the use of percutaneous Kircher guide wires, closed reduction external fixation, or open reduction internal fixation if the fracture is massively comminuted. What is a Boxer's fracture? A Boxer's fracture involves the distal 4th or 5th metacarpal. It is at the knuckle. It is the metacarpophalangeal joint. Occurs more commonly in males. It's usually due to a traumatic blow with a punch with a closed fist or direct trauma to the knuckle. The clinical features are there's painful erythematous swelling at the penultimate or final knuckles, and there is also limited movement of the finger of the affected knuckle. The X-ray would show a fracture as shown here at the distal portion of the 5th metacarpal. Remember that it can also affect the 4th metacarpal. Management is either conservative, closed reduction using a splint or a cast, and surgical we can opt for is ORIF. Part 3b, pelvic fractures. There are 3 types of pelvic fractures, and they are classified based on the A of trauma classification. I would recommend that you search up a picture for this in order to understand this a little bit better. Type A is stable and minimally displaced. Type B means it is rotationally unstable, however vertically stable. And type C means that it's both rotationally and vertically unstable. Type C naturally is the worst of them all, and type A is usually the best of them all. So a pelvic fracture. A pelvic fracture is a fracture of the pelvis involving the ilium, the ischium, and the pubic bones. It is the common site for osteoporotic fractures. It's a common site for osteoporotic fractures in elderly ladies, and it's usually and the peak incidence funnily enough, occurs at the ages of 15 to 28. 20% of patients with multiple trauma generally tend to have pelvic fractures. The etiology or the causes include road traffic accidents, high impact road traffic accidents, and also falls. This is especially seen in the elderly. The clinical features are pelvic pain, worsened by weight bearing, and reduced range of motion of the hip. Pelvic tilt or uneven leg length is possible. The complications that I recommend that you take a look and actually learning as well before your exams. Concomitant injuries may also occur, so urethral injuries. So the posterior membranous urethral portion, especially in males, can be affected by a pelvic fracture. Swollen perineal area, a superior displaced prostate, and blood at the urethral meatus. Bladder injury would result in frank hematuria or gross hematuria, and also neurovascular injury. It may affect the superior gluteal nerve. The superior gluteal nerve is responsible for innervation of the gluteus medius and the gluteus minimus, whilst the inferior gluteal nerve is responsible for innervation of the gluteus maximus. It may be confusing, but I recommend that you do learn this off by heart. If there is damage to the superior gluteal nerve, naturally it would result in a positive Trendelenburg sign. This can cause increased rectal tone, perianal paresthesia, and also vascular injury, which can, in the form of arterial injury, superior gluteal vein and artery, which may be injured. The investigations that we would recommend for these patients are slightly different from the regular because there are other concomitant complications which may occur. Investigations generally tend to include X-rays and CTs to actually visualize the fracture itself, an angiogram of the superior gluteal artery to take a look if there is actually any vascular injury present, and an ascending urethrogram just to assess the patency of the urethra and assess for any other injuries that may be present. Management is obviously fixation of the fracture, and also the use of a suprapubic catheter. If there is urethral injury, I would recommend a suprapubic catheter, as passing a catheter through an injured urethra would not be pleasant for any patient. So therefore, we bypass the site of injury and go directly from above into the bladder. Femoral fractures. So there are two types of femoral fractures. There are internal femoral fractures and there are internal capsular fractures and external capsular fractures. So fractures of the femoral neck and the femoral head. There are also external capsular fractures, intertrochanteric fractures, which are between the greater and the lesser trochanter, and also subtrochanteric fractures, which are fractures below the trochanters. This portion is located within the capsule. This portion is located outside of the capsule. The capsule line is usually the intertrochanteric line. So, proximal femoral fractures, or hip fractures. These are an important one to know for your exams. Fractures of the hip, which are classified anatomically depending on the site affected. The etiology of the causes are falls, especially seen in osteoporotic patients on the lateral aspect of the hip, or road traffic accidents, more common in younger patients. The risk factors generally are low body weight, as low body weight means that there are less forces acting on the bone, therefore the bone is more likely to be osteoporotic. Muscle weakness and impaired coordination and difficulty walking. Classification is classified either according to the location or according to the Garden system. I'd recommend that you look up the Garden system. It's a little bit complex at an undergraduate level. However, if you do have an interest in orthopedics, feel free. So what are the clinical features that you tend to see in a proximal femoral fracture? These are the general characteristics of each type of fracture. It's important to know that there is a fracture, or you can have a fracture of the femoral head, femoral neck, which is intracapsular, trochanteric, subtrochanteric, and intertrochanteric, which are extracapsular. So generally what you tend to see that there is groin pain of the hip. It's shortened and externally rotated, and there is also localized swelling. In cases where it's the femoral neck, there is minimal bruising because it's intracapsular. There's also no bruising in the femoral head fracture. The femoral head fracture is commonly associated with a posterior hip dislocation. The femoral neck fracture is the most common type of fracture. Trochanteric fracture is, if there's lesser trochanter, there would be worse pain on flexion and rotation. The leg is also shortened and externally rotated like any other hip fracture. The greater trochanteric pain is worse on abduction. X-rays are obviously the investigation that you tend to opt for. If the X-ray is inconclusive, an MRI is the gold standard. It's an intracapsular fracture. Generally, the management, it depends on whether it's displaced or non-displaced. If it's non-displaced, we can tend to use internal fixation or hemiarthroplasty. Whereas if it's displaced, young and fit, under the age of 70, open reduction and internal fixation within 6 hours, old and unfit, greater than 70, hemiarthroplasty or total hip replacement. A hemiarthroplasty is preferred in frail patients as opposed to a total hip replacement. Extracapsular, you can opt for either a dynamic hip screw or an IM nail. If the fracture is transverse or subtrochanteric, then we would generally tend to opt for an IM nail. You should weight bear immediately with an IM nail. Thank you very much for watching my brief mini web series on orthopedic fractures with S-Docs. If you have any questions, then please feel free to direct them to me. Below is my website. Below is my email address. These are the references that I would use, and I would recommend that anyone interested in orthopedics or generally studying for undergraduate medical exams would tend to follow or use these 3 resources. Thank you very much.